Okay, let's start with hemifacial atrophy today. So, coming to the hemifacial atrophy, it is a condition affecting the female children of age group of 5 to 15 years, and it is more common in the age group of 10 years. So, today we will see hemifacial atrophy. So, this picture shows the clinical features of hemifacial atrophy. See, this patient is having the atrophy over the midline, that is depressed bones and subcutaneous tissue is atrophied, and the shape of the skin is somewhat hyperpigmented, and you noticed that chin lift picture shows clear differentiation from the left side, right side to left side. So left side of the patient is normal, right side it's look like depressed. So this is hemifacial atrophy. See, you see that picture, that patient is having that affecting the forehead and cheek and the lip also, lateral side of the lip and chin area also, the have extended the thing, and she is having also alopecia, loss of hair over the scalp and the eyebrow also. So these are all the features you are seeing this picture. So we have to see this hemifacial atrophy today. So coming to the hemifacial atrophy, it otherwise called as the Parry Romberg syndrome. So that is Professor Parry is first described this syndrome. So this is otherwise called as idiopathic progressive hemifacial atrophy, IPHA, and Parry Romberg syndrome. He described first this syndrome, and N-cup D-Sabe, ECDS. So and localized scleroderma. So these are all the names. It is called because of that localized scleroderma and N-cup D-Sabe are subtypes of this hemifacial atrophy. Coming to the molecular mechanism of the disease, it is mostly due to autoimmune disease. That is due to anti-nuclear antibody, like activation of that scleroderma. So autoimmune disease, that is the disease progress will gives rise to this problem. So the patient is having the autoimmune disorder of the own cells. It is producing antibodies, and it will target the own tissue and get this problem. So this patient is mostly affecting the skin, subcutaneous tissue, bones, and neural systems. So this is one. This is, and other hypothesis like infection hypothesis and traumatic hypothesis, like that they will discuss. In infection hypothesis, the mostly Borrelia burgdorferi organism is having the disease progress. All the patients with it is having that Borrelia burgdorferi infection. Coming to the epidemiology, it is affect 5 per 10 lakh people, and it is female predominant disease. Females are most affected. That is 3 is to 1. Female is male. Ratio is 3 is to 1, and that is 2.2 to 3. That is the female predominance and 1. And coming to the affected is 10 years is the most affected age group. The years varies between 5 to 15 years. and the disease is progressed 1 to 2 years. After that, it halt of the disease is there. So after that, it will not progress. So this is the specific feature of hemifacial atrophy. Coming to the clinical manifestation, I already told you it is mostly affect that skin subcutaneous tissue and our CNS. So coming to the cutaneous findings, so hyperpigmentation, hypospigmented parts, like that we have seen, and alopecia of the scalp and eyebrow, eyelashes also noted. Coming to the subcutaneous, atrophy of the fats is noted, and it is mostly first affected the cheek, and it is go to temple and forehead and chin area. Like that, it extends. So it extends the brow angle of mouth and neck, like that. And musculoskeletal involvement, the facial musculature is undergo atrophy and thinning out of the muscle. That frontalis is mostly affected, and cheek muscles, facial muscles is affected, and mesenteric also affected, and tongue muscles also affected. Coming to the CNS involvement, we have seizures, hemiparesis, migraine headaches, neuropsychiatric disturbances, ischemic stroke, and intellectual deterioration. So all these things is coming under the CNS involvement. Most of the patient is present with seizures and facial atrophy. So that is the two main presenting symptom of the patients. Most of the patient getting treatment in neurologist and referred to plastic surgeons. So ocular involvement and oral involvement because of that facial atrophy and tongue involvement, and ocular involvement due to eyebrows and loss of function, and all these clinical manifestation is occur. Coming to the treatment, we have the medical management and non-surgical management and surgical management. So the disease pathogenesis is having the lymphocytic vasculitis. Because of the autoimmune disease, that lymphocytic infiltration over the vascular territory, so that will produce thrombosis and atrophy of the part is one hypothesis is there. So that is the pathology noted, and treatment is, because this is mostly due to autoimmune cause. So we have to rule out autoimmune disease. We have to make investigations. Investigation is mostly for CNS involvement. We have to do MRI and CT scan and look all the findings is there in CNS. And for subcutaneous tissue, we have to take histologic features of that area, that which shows lymphocytic infiltration, and other things is according to the specific symptoms we have done investigations. And coming to the other investigations, to confirm, we have to do anti-nuclear antibody testing. That is for autoimmune disorder, we have to anti-nuclear antibody testing. So that shows the autoimmune disease. And coming to the treatment part, we have to treat medically with corticosteroid. It is autoimmune pathology, so we will treat it with autoimmune disease, like we will treat it with corticosteroids and methotrexate. So this will take for 2 to 5 years, because that disease progress is 2 years now. We will get treatment for 2 to 5 years. Because of steroid and methotrexate toxicity, we will taking care of the patients. And coming to the non-surgical treatment, we use pillars for non-surgical management, and surgical management, we will do fat grafting for cheek and forehead region and local flaps to cover the defect and pre-flap. Most of the patient we have done pre-flaps because the facial atrophy, the atrophic part of the bone, subcutaneous tissue and cheek tissues, we have done pre-flaps. Mostly ALT and long flaps like LD, that is done. So that is the treatment available for that hemifacial atrophy. That is immunosuppressive treatment, that is corticosteroids and methotrexate, and non-surgical intervention like fillers, and surgical intervention like we have done dermal fat grafts and we have done local flaps and free flaps. So the pathology I already told that lymphocytic vasculitis is the main pathology noted in the histologic features. Thank you.